Good morning, everyone. Welcome to HIV Grand Rounds. I'm going to encourage everyone to take a seat so we can get started with our very high yield talk today. We have two speakers today to talk about updates in hepatitis management among people living with HIV. We're really lucky to have Dr. Jessica Briggs and Dr. Jenny Price here to share their liver lessons with us. So Dr. Jessica Briggs is an assistant professor of medicine in the Division of HIV, ID, and Global Medicine. And in addition to being a clinician investigator and phenomenal malaria researcher, she is also the hepatitis C lead for our clinic at Ward 86, and will speak first. And then she'll be followed by Dr. Jenny Price, who's an associate professor of medicine and hepatologist, who leads a number of really exciting interventions. One of many is the Deliver van, which you may have seen around town, and really focusing on novel ways to engage and treat Hep C in people living with HIV and without HIV. So I will turn the microphone over to them. One quick note, they have a lot to cover. So we are going to take questions at the end. So you can put your questions in the Q&A section if you're on Zoom, or hold on to them, but we'll get through them and leave enough time, hopefully 5-10 minutes, and I can wave at you at the end. Without further ado, let's welcome Dr. Briggs and Dr. Price.
Hi, everyone. Thank you for that introduction. Quick disclosures, I don't have any, and then Dr. Price's are listed here. And here's a quick outline of what we're going to cover today. We're actually going to review the San Francisco Hepatitis C surveillance report to learn more about the epidemiology of Hep C here in the city. And then we're going to just discuss quickly the treatment of hepatitis C, and then some research updates on adherence and SVR when there are adherence interruptions. And then Dr. Price is going to cover a new and exciting HCV RNA point of care test and discuss ways that we can get to hepatitis C elimination. And then we will review hepatitis B vaccine. She will review hepatitis B vaccination and reactivation, and then talk about hepatitis D. So lots to get through, as we stated earlier. So I just thought that last year when we presented hepatitis C data, we talked more about national data, but I thought that it would be fun to review the San Francisco hepatitis C data that was just published a couple of weeks ago. And so here you can see the number and rate of newly reported hepatitis C cases. So this covers 2021 through 2023. And then they're shaded as confirmed, which means that the person had a positive hepatitis C viral load, and probable, which means they had an antibody but without confirmed hepatitis C viral load. And these are newly reported from 2021 on. And you can see there hasn't been much movement in the rate of these newly reported cases. It came down a little from 2021 to 2022, but it's been stable since then. And for new cases, about 57% were confirmed. So that does highlight a gap, of course, in confirmatory testing of newly reported hepatitis C cases. In San Francisco, the majority of hepatitis C cases are in men, and they're colored here in orange. And you can see the females are colored in blue. Let's see if this works. Yeah. And so there's not much difference in sex between all reported cases and newly reported cases, but there is a big difference in age categories. So newly reported cases are much more likely to be younger, less than 45 years old. And looking at racial and ethnic disparities in hepatitis C. So here, this is what the population of San Francisco actually looks like. And then there are two populations that are really overrepresented in terms of hepatitis C cases, white Caucasians, and then Black African Americans really unfortunately outperform their percentage of the overall SF population. And I also thought this was interesting. We show that they can show that the neighborhoods that have the most active hepatitis C infection as of December 2023 are the Tenderloin, South of Market, and Mission neighborhoods. So how good are we doing in San Francisco with treating hepatitis C, getting people who are identified as positive all the way to cure? And so here is the number of people that were ever infected. And we have about an 18% here not receiving an RNA test. And then if you do have the virus detected, only 37.5% of those people are making it to clearance or cure documented. And so obviously there's some room to do better here. And then there are certain populations that do worse in terms of achieving clearance. Younger people between the ages of 25 and 34 had the lowest proportion of cure. And there are also disparities by race, with African Americans having a lower proportion of cure. And for the first time, actually, I think this surveillance report was able to match hepatitis C cases to HIV cases in the city. And actually, the clearance cascade for those people living with HIV looks better compared to the general population. And I think that's really encouraging. So if you're a HIV provider, pat yourself on the back, because you're probably contributing to this. But instead of it being 37% of people achieving cure, we're almost at 66%. Known risk factors for confirmed hepatitis C in people living with HIV are MSM, injection drug use, and persons experiencing homelessness. And so I think in summary, what this document is showing is that there are a lot of opportunities for improvement. One of those would be confirming active infection in people who have a positive antibody. There are still clear racial disparities in our San Francisco populations and those who achieve cure. And then, of course, making sure that we screen those with these known risk factors and connect them to care as quickly as possible. And just to compare our rates of achieving clearance and cure with overall data from the United States, you can see that 1 in 3 people are achieving cure overall in the US from 2013 to 2022. So we're just barely outperforming them, 37.5% in the whole of San Francisco. But we are doing much better in our population of people living with HIV. And of course, I want to emphasize that we should, of course, be doing better because we have really, really, really highly effective drugs for everyone who has hepatitis C, and we still just aren't reaching enough patients. So as a quick reminder about those regimens for hepatitis C, so we have GLP or GP, brand name Mavyret. This is a pan-genotypic regimen that is 3 pills once daily for 8 weeks. People often prefer this if they want to get treated in the shortest time possible. And one of the major drug interactions that you'll have to worry about is with HIV protease inhibitors, but there are other ones that you can always look up if you're worried. And the alternative for a pan-genotypic regimen would be Sofvel or Epclusa. This is also a pan-genotypic regimen. It's 1 pill daily for 12 weeks. And the one thing you really need to watch out for is the patients who are on acid blockers. And patients tend to prefer this medication when they have a high pill burden and they don't care so much about quick treatment. They just want to have fewer pills. The side effects of these are generally mild. Sometimes people do complain of headache, nausea, or fatigue, and those symptoms tend to get better as you continue taking the drug. Generally, this is not something that leads to people stopping therapy. So now we're going to move on to some hepatitis C cases. This patient has a history of HIV, well controlled on Biktarvy. His risk factors for hepatitis C are MSM and IDU. And he actually has a previous treatment for hepatitis C, genotype 1A, back in 2020 with Sofvel, which is Epclusa. We did document that he had sustained viral response with a negative viral load 12 weeks after he completed therapy back then. He has no cirrhosis by FIB4, but you notice suddenly that there's elevated LFTs when there weren't prior. You screen with a viral load because he is still positive for his antibody from before, and he's positive by viral load. So what treatment would you give this person who's been treated in the past successfully with documented SVR? Would you do A, GP times 12 weeks, that's Mavyret, or Epclusa times 12 weeks? Would you do GP times 8 weeks or Sofvel times 12 weeks? I'd really like a genotype. Or D, he's a retreatment, so he needs Vosevi. And I think, is it on? Okay, I just advance. when I'm ready? Okay, I'll give you a little bit more time. I think it used to pop up. Oh, it's active. I love it. All right. How many people? I can't tell. So the majority of people here have selected what I would say is the correct response, which is B. So you don't need a genotype before deciding because we have 2 pan-genotypic regimens, right? And this person has documented clearance in the past. So I would, because this person we've documented that they cleared, they're actually just like a reinfection with a new infection. And so they're basically the same as a treatment naive person. And they just get the standard therapy, whether that's Mavorite for 8 weeks or Epclusa for 12, depending on patient preference of pill burden and duration of therapy. They can just be treated as if they are treatment naive. So A is wrong because you don't need to extend the Mavorite. You don't really need a genotype to decide this. And Vasevi would be the correct answer if we were worried that they had been a treatment failure, right? So let's talk about something that happens all the time. So it's the same person, and he was treated in 2020, and we know that his genotype back then was 1A, but we don't know what he was treated with, and we did not document SVR. And everything else is the same, no cirrhosis. He has elevated LFTs. You screen with a viral load and he's positive again. So what information might be useful here? What he took last time in 2020, what his new genotype is, or resistance testing of his current infection. This is fun to see it in real time. All right, we have a tie for B and C. Someone who chose B in the room, does anyone want to volunteer why? No volunteers. Anyone who chose C want to volunteer? Fine, I'll just tell you the answer. So for B, I think the answer is B here, because if you knew, we know he was 1A before, and if you get a genotype this time and he's a different genotype, then you actually know that he's been reinfected and you can treat him as a reinfection, right? And he'll have a shorter course of therapy. But if you don't have, let's say he, that depends though, if he has a different genotype or not, right? If he has the same genotype, it won't be that useful. Resistance testing is generally unnecessary with some exceptions, which we'll talk about. And I don't think necessarily knowing the prior regimen is useful in this case because it's not going to change the outcome of what you treat him with. So when you re-genotype him, it just shows 1A again, which is the most common genotype, right? So that is likely to happen. And so you're unable to distinguish between reinfection or treatment failure. And so in that case, you just assume in that case that this is treatment failure because you're not sure. And then that will lead you down the algorithm to soft Velvox, which is Vasevi. And generally, that recommendation is going to be 12 weeks of Vasevi. And that's all you need to know. There's no need for resistance testing. There might be some cases if you had genotype 3 where you might want to get a genotype. But other than that, do resistance testing. But other than that, you don't need resistance testing here either. So just a reminder for hepatitis C screening, you should screen all adults at least once, and you should always screen any pregnant women for hepatitis C. And then for those patients with ongoing risk factors, you're going to want to screen every 6 to 12 months, including for injection drug use, MSM, or patients on PrEP. And any person who has a long-term sexual partner with hepatitis C that isn't treated, although really you should try to get your partner treated if you identify that as a risk factor. And just a reminder that if they have been treated in the past, their antibody will remain positive and you'll have to screen with an RNA viral load. So let's talk about another case. which I also feel like is quite common in our treatment settings. So Mr. J has a history of HIV while controlled on Biktarvy, and his risk factor for hepatitis C is just injection drug use. And he's been diagnosed with hepatitis C after coming in for care. He has no cirrhosis, normal renal function, and you start Mavyret because he really wants 8 weeks of therapy, a short course. And then you touch base with him over the phone 4 weeks later, and he reports that he took 2 to 3 weeks of medication, but he has missed approximately 10 days of meds since then. So what do you do next? Do you A, get an ultrasound, B, tell him just restart your meds and we'll just finish the course for 8 weeks, C, restart your meds and actually extend for 4 weeks more, or D, restart meds, check a hepatitis C RNA on the same day if possible, and then depending on that result, if it's positive, extend therapy by 4 weeks. I'm going to wait to advance because I do feel like there's some bias when people can see the answers coming up. Okay, we're sort of split between B and D. And I would say this is a tricky, oh, now we're completely split. I would say this is a tricky question because these are the types of questions that I'm often emailed about or asked about, because providers generally, I feel like, don't have a good concept of what to do in these situations because they're a little tricky. But what I want to alert everyone to is that there's actually guidelines now on how to address these adherence challenges. So the correct answer, according to the algorithm that was published in the IDSA guidelines in 2023, would be to tell him to restart, check the RNA, and then extend therapy depending on the results of that RNA test. So, right, so here's the algorithm, and it's actually quite extensive and even tells you what to do for certain genotypes and whether or not they have compensated cirrhosis. So in this particular case, he's an interruption before 28 days. He missed 10 days. And so you go down to here, this algorithm, you would say, go ahead and restart your meds. You try to get the RNA as soon as possible. And if it was negative, then you're like, oh, well, he had enough to suppress his RNA, right? And we feel comfortable with just doing the initial course, unless they have compensated cirrhosis or genotype 3 infection, in which case you would extend anyway. But if their HCV RNA is positive or you can't get it, then you just extend. And I have seen patients for whom we have not been able to get that RNA and in a timely fashion, extend the therapy for 4 weeks and achieve SVR. So that is possible. And so truly that means that like C would have also been a fairly legitimate answer. And then here, there's also an algorithm for what to do if there are interruptions after receiving a month of therapy that are, again, quite detailed. So I just wanted to, pull everyone's attention to the fact that these are available. The link is here at the bottom, and it can be really helpful to guide what you do if you find out that your patient has experienced a treatment interruption. So I just wanted to review some of the data about like minimal monitoring. You might say like, oh, well, I'm worried about starting hepatitis C therapy and my HIV positive patient. What if they aren't able to come and check in with me and all I can do is really contact them over the phone and check in? Are they still going to have like a high rate of achieving SVR? And we reviewed this data in the last hepatitis C grand rounds last year. So I just want to remind everyone that this was about 400 patients on Epclusa. They had no genotyping data. They got all of the meds at entry and no clinic visits or labs, and just a phone call at 4 weeks and 22 weeks. And of those patients, 42% were living with HIV. And really there was no difference between SVR rates in those with and without HIV. So a minimal monitoring approach is safe and effective in patients living with HIV. And then there's additional data that just came out looking at the genotyping data from the study. So out of the 29 patients who had a positive hepatitis C RNA at or after the SVR visit, which means that they were either a treatment failure or a reinfection, they did paired genotyping of their baseline infection and then their positive RNA either at SVR or later. And of those 29, 17 people were actually found to have reinfections. And interestingly, I thought this was interesting that 6 of those reinfections were detected at the SVR visit, which means they were reinfected really fast. And then the remainder were at 48 or 72 week visits. The other thing is that almost all of these patients who were reinfected had the risk factors of HIV, MSM, but this was a multi-site study. And actually, the vast majority of reinfections occurred in Thailand. So there's also, so the patients in Thailand were at particularly high risk of reinfection. And so I don't know how translatable that in particular is to our population, but it's clear that HIV and MSM are risk factors for reinfection. And then the other good piece of news is that there was no difference in SVR or cure between those with a baseline resistance mutation and those without, right? So there's a tiny difference here, but this is not statistically significant. So that's more encouraging data that you don't need a genotype to get people started on therapy. And then I think we always worry about our patients' adherence. Certainly it's something we experience a lot of people who have treatment interruptions, but the good news is that it is not necessary to have perfect adherence to achieve SVR. And so we also talked about this HERO study last hepatitis C grand rounds, but there's some additional information was released on this as well. So this was a study where they randomized 755 people who use injection drugs who have hepatitis C. They gave them electronic blister packs so they could really tell exactly how many doses of a 12-week Epclusa regimen they took. And you can here, they're just showing the percent of people either per protocol or by modified intention to treat who achieved SVR by how many days of therapy they took. So actually, even with just taking 50% of your meds, many people, like over 90% of people achieved SVR. If you took less than 50% of your meds, then the more days of meds you took was associated with better, with a SVR. And then long treatment interruptions of 2 weeks or greater and early discontinuation were associated with lower achievement of cure. But the overall message that I would take away from this is that you do not have to be perfect in taking these medications for them to work. And so practically, I would say checking in with someone at 4 weeks is a really good way of reminding them that that adherence is important. I think they also showed that in a different study that if someone reported low adherence at 4 weeks, that was a poor predictor of SVR as well. So checking in at 4 weeks, if you're able to get a viral load at 4 weeks, if they happen to be in the clinic, that can also be helpful. But again, you can be reassured that SVR can be achieved even with low adherence. So summary for my portion of the talk here is that reinfections are quite common in those with certain risk factors. So screen your patients often who have those risk factors and remember to use a viral load if they've been treated before. If you've treated someone before and if you've documented clearance, you can just treat them as a reinfection or a treatment naive person. And if they are a treatment failure or you don't know, then you'll usually need to treat with Vasevi. Minimal monitoring approaches are safe and effective in both patients living with HIV and patients who use injection drugs. And even though adherence issues are common, they can be managed and you really do not need perfect adherence to achieve SVR. So really just a motivating factor to get your patients treated as soon as they say that they're ready. And now I'm going to turn it over to Dr. Price.
Okay, thank you. So I am going to take over now. I just have one update on hepatitis C, and then the rest I'll talk about hepatitis B. But I wanted to update the group on what is new with hepatitis C elimination. So as many of you probably heard, maybe at the last year's Hep C grand rounds, there was an announcement in March of 2023 by Francis Collins that the Biden White House had a new national hepatitis C elimination program. So this was really exciting, big news in our field. The main backbone of the program were 3 main priorities. So first, accelerating the availability of point of care diagnostic tests. Second, providing broad access to DAAs, for example, through a national procurement plan. And then third, building the public health infrastructure to really support identifying people living with hepatitis C and linking them to treatment. So this program that has now moved into the phase of bill, which is currently in the Congressional Budget Office getting scored. So that's sort of the status of where that is. But the work is sort of advanced without the necessarily the funding behind a program. And the first priority for the accelerated point of care testing has actually made a lot of progress. In this summer, the FDA approved the first point of care Hep C RNA test. So this was also really big news for us. This was in June, and so this is now available. It's the Gene Expert Express platform, and I just wanted to walk you through how it works. It uses capillary blood, so there, you get a finger stick, and then fill this little microtainer. I hope this has a pointer. There we go. Okay, so this little microtainer with the blood, and then the kits come with a pipette, so you could put the pipette the blood into this cartridge, which looks like a printer cartridge, and then put it into the system, and it takes about 60 minutes to get the results. The results are qualitative, so positive or not positive, and it can be reported in as little as 41 minutes. So with this availability, we can now kind of start thinking realistically about a test and treat approach for hepatitis C, potentially even same day. And so the AASLD, IDSA guidelines have been anticipating this and talking about this. We recently have updated the guidance. It's not formalized yet, but will be soon. But this is sort of a way to think about the approach. This isn't the official guidance at this time. But one way that you could envision testing and treating in the same day was doing the point of care Hep C RNA, point of care HIV test, if applicable point of care pregnancy test. If the Hep C RNA is detectable, then assess your patient for eligibility and appropriateness for same day treatment. We would consider people to really not be appropriate for this if they have prior DAA experience, if they are known to be Hep B surface antigen positive, or have other sort of complicating factors like known hepatocellular carcinoma or a history of decompensation. But I'd say most of our patients who test positive for Hep C RNA don't meet these ineligibility criteria and then could be conceivably eligible for same day treatment. If that's the case, then you would want to do counseling of the patient, do a medication reconciliation, draw pre-treatment labs. And I would say the minimum pre-treatment labs we would recommend are the AST, ALT, and platelet count, which will allow you to calculate the FIB4 to non-invasively assess for cirrhosis, and a hepatitis B surface antigen if this hasn't already been done. Then you could start either of the two regimens that we already heard about, Mavorite or Epclusa. The important caveat here is that we don't yet have a point of care hepatitis B test. So if you do elect to go this route without knowing the hepatitis B status, it's important to have a follow-up plan in case your patient does test positive for hepatitis B. There is a small but still there risk of hepatitis B reactivation in the setting of DAA treatment for hepatitis C. So that's all I have for hepatitis C. And then I was going to move on to some hepatitis B cases. So this is a case of a woman with a well-controlled HIV and Biktarvy presenting for care. Her hepatitis B serologies and Hep C were all negative in 2022, and she recently completed the 3-dose Endrix B vaccine series. So what would you do next? Feel free to shout out an answer, or I'll just move on. Draw an antibody. Yes, so after Hep B vaccination, we should check antibody titers 1 to 2 months after the vaccine in people living with HIV. If the titer is over 10, then your patient is a vaccine responder. You can consider annual antibody testing and then giving a booster if the titer falls less than 10. But if the antibody titer that you check after the vaccine is less than 10, then your patient's a vaccine non-responder, in which case we recommend revaccination with either a second round of the 3-dose vaccine series, recombinant Hep B vaccine, or a 2-dose series of the HEPLISAV-B. So these were recommendations from a couple of years ago. We now actually have new data on HEPLISAV-B in people with HIV, and that was from the ACTG Beehive study. So this was published a year ago. This is the arm that was assessing the efficacy of HEPLISAV-B in vaccine naive participants with HIV. And they received 3 doses. So at 0, week 4, and then week 24. And the bottom line here is that the seroprotection rate was 100%, so quite high. Leading to the question of, are 3 doses really necessary? You can see here at week 24, so after just receiving 2 doses, it was nearly 100% seroprotection rate. So really, really high effectiveness of this HEPLISAV vaccine. The second part of the study was assessing the efficacy in vaccine prior non-responders. And this was presented at CROI last year. And so there were 3 different arms of this study: the standard Endrex 3-dose arm, the HEPLISAV-B 2-dose arm, and then HEPLISAV-B 3-dose. And bottom line here, you can see the seroprotection rates were 93% with 2 doses of HEPLISAV-B and 99% with 3 doses versus 81% in the Endrex-B. So take-home message: in your vaccine non-responders, I would recommend the HEPLISAV-B vaccine, at least the 2 doses as the guidelines recommend, and maybe consider a 3rd dose. Now, let's go back to this case. Let's say her surface antigen was negative, surface antibody was negative, but core antibody was positive, and now she really doesn't remember her Hep B vaccine status. So now what would you do? What's that? You could get a Hep B viral load. That is one option. I was thinking in the context of the vaccination, but that will come up in the subsequent case. So this is sort of, what do you do with the isolated core antibody positivity and you don't know their vaccination status? So there's like sort of 2 possibilities here. This could be a prior infection with clearance of the surface antigen, or it could be a false positive. If it is prior infection with clearance, there should be a robust response to just 1 dose of the vaccine. So the recommendations are to just give 1 dose and then assess the surface antibody titer and see what the response was. If it was over 100, then you can stop. But if it was less, complete the remainder of the vaccine series. Or if the surface antibody titer is just, it's not feasible for you to draw, just give the whole vaccine series. So I guess the key point here is that you do want to vaccinate somebody who has anti-core positivity isolated, but the number of doses you give is going to depend on their response to the first. Okay, next person, also another person with HIV, well-controlled on Biktarvy. This patient's interested in switching to ART regimen without antiviral activity for hepatitis B. He, like the prior patient, is surface antigen negative, surface antibody negative, and core antibody positive. So what do you do next? We heard the check a Hep B DNA. Yeah. And the serologies were from 3 years ago. Recheck serologies. Yep. Okay, so we will get to the answer to that. Both are correct answers. But first, I just want to remind you about the risk of hepatitis B reactivation after surface antigen loss. So after the hepatitis B virus enters the hepatocyte, the genetic material enters the nucleus and gets converted into this covalently closed circular DNA. And this then becomes the template for mRNA transcription and for viral replication. And even after people lose their surface antigen, this cccDNA remains in the nucleus of the hepatocyte. So this is what we do not know how to get rid of. And we don't naturally get rid of this, even with clearance, and what can be the risk for reactivation in the setting of immunosuppression. But also we now know that this can occur in the setting of switching to an NRTI sparing ART. And there have been a number of case reports, I would say relatively small series in the literature. In my own clinic, I've seen a handful of cases like this, people who were surface antigen negative before their switch, but then had hepatitis B reactivation. There was one relatively large study that was presented at the ID Week last year in 2023, looking at trying to kind of quantify the risk of reactivation. This was among people with HIV in the VAX cohort. There were a lot of people that had a core antibody positivity, 21,000, but they looked at the sort of at-risk group for reactivation. So these are people who were core antibody positive, switched to an ART without Hep B activity, and were surface antigen negative, and if their DNA had been checked, were DNA negative. So sort of the at-risk group that we're thinking about, and their primary outcome was reactivation, which they defined as new surface antigen positivity and or newly detected Hep B DNA. So there were, around 21,000 people who are core antibody positive, about 6,000 that were in this at-risk group. Interesting here, you can see here that most of the people never had a positive Hep B surface antigen, and then some had a positive surface antigen, but then seroconverted at some point. So they had a documented surface antigen negative. But the key thing here, I think, is they looked to see if people ever had surface antibody positivity. And then looked at that in those with and without prior surface antigen positivity. So I'll just point you, there's a lot going on this slide, but just here, these are the really confirmed cases that actually occurred after the switch. And what you can see here is that the highest risk of reactivation were in the people that never mounted immunity, so never had surface antibody positivity, particularly those who were at surface antigen positive at some point in the past. So how should you approach these patients? Every place has a little bit of a different approach. This is the UCSF approach. As Annie said, obtain new Hep B serologies if they are old. So you want to know what the status is, at least in the past 6 months before you switch the ART. If they are isolated core antibody positive, consider checking hepatitis DNA. That's sort of what we call occult hepatitis B. So that's when the DNA is positive, even with a negative surface antigen. And then really important, just remember to put Hep B core antibody positivity in the patient's problem list. So that sort of reminds people that the patient is at risk for this reactivation. So actually, even in all of my patients that I see that are core antibody positive and surface antigen negative, I just always put that in their problem list. As you can imagine, I do a lot of hepatitis B serologies. So then here's sort of the protocol or algorithm. If they're surface antigen positive or DNA positive, don't stop the Hep B active ART. So that's like the most important thing, because every so often it is stopped, and then that can lead to really severe reactivation, even leading to need for liver transplant or death. But assuming that the surface antigen is negative and the DNA is negative, if their surface antibody is negative, that's the group that probably is at the higher risk. I would consider vaccinating them first to see if they mount antibody response, but that's not necessarily required. But you really should sort of use shared decision-making in this case to talk about the risk of reactivation. If their surface antibody is positive, that risk, like I said, is lower, but still there and still warrants discussion. And I think the most important thing is just remembering that they are at risk, and to follow their liver tests regularly and have a low threshold for checking a DNA or surface antigen if the liver enzymes rise. If they're core antibody negative, and they're surface antibody positive, go ahead and make the switch. You don't have to worry. If they're surface antibody negative, you can make the switch, but you also want to make sure that you vaccinate them. Okay, one more case. So this is another patient, HIV well controlled on Biktarvy. His surface antigen is positive, his DNA is, Hep B DNA is undetectable, and his ALT is 80 and AST is 65. So assuming all of these things are orderable for you, what would you order? Abdominal ultrasound, vibration controlled transient elastography, also known as FibroScan, hepatitis delta antibody, or all of the above? Oh. All right, everybody. Everybody is in consensus that it's all of the above. I agree. So the abdominal ultrasound is useful. First of all, to assess for hepatocellular carcinoma. I didn't tell you the age of the patient, so we don't know technically, whether or not he meets criteria, but it's also useful in this case with the elevated liver enzymes. You want to see if there could be some other cause, and also to see if there's obvious cirrhosis or portal hypertension. The FibroScan helps with fibrosis staging, and also will tell you if he has steatosis, which is probably the most common cause of elevated liver enzymes in somebody living with HIV, who, even if they also have Hep B surface antigen positivity, there is the controlled attenuation parameter, or CAP score, which is elevated with steatosis. So it would be helpful in that scenario. And then the hepatitis delta antibody is important for screening for hepatitis D. And this is obviously a hepatitis talk. So, in this case, I'm going to be talking about hepatitis D. So just to remind everybody, hepatitis D is the small defective RNA virus that requires hepatitis B surface antigen for transmission and packaging. So you can't have D without B. Sort of clinical pearl is that in people not on antiviral therapy who have B and D co-infection, the hepatitis B DNA is often very low or even undetected. And that's typically due to suppression from the hepatitis D virus. So when I see a patient who has Hep B surface antigen positivity, is not on antiviral therapy, has really low or undetected hepatitis B DNA, but has sort of disproportionately high liver enzymes, I have a higher degree of suspicion that they could be co-infected with hepatitis D. There's sort of two different ways that people will acquire hepatitis delta. So one is getting the B and D at the same time, so co-infection at the same time. When this happens, there's typically a more severe acute hepatitis than with hepatitis B monoinfection, and there's also a higher mortality. And in this case, the fate of the delta is really determined by the host response to the hepatitis B. And then the other scenario, which is important to remember, is that there can be a hepatitis delta superinfection in somebody who's hepatitis B surface antigen positive, even if they're on antiviral therapy. And this can manifest as a severe acute hepatitis or an exacerbation of the underlying chronic hepatitis B. It might be a little confusing because you think it's a hepatitis B flare, but the hepatitis B DNA is still undetected. And this scenario usually results in chronic hepatitis D infection. So hepatitis delta is important because co-infection with B and D is associated with significantly higher risk of developing cirrhosis and liver decompensation and HCC. So if you look at our transplant list, for example, on our list of people with hepatitis B, the patients that have delta co-infection are sort of enriched in the transplant list because they're much more likely to develop decompensation and liver cancer. So what about hepatitis delta screening? Well, on the left here is a screenshot from the most recent AASLD guideline in 2018, which is still risk-based screening for hepatitis delta. You can see the whole list of risk factors here. People living with HIV is on here, so you want to screen any of your patients living with HIV. I will say in the hepatology clinic, we test everybody. I mean, I think all of my colleagues also. Everybody with hepatitis B surface antigen, we do one-time testing. The WHO recently updated the hepatitis B guidelines and recommends universal hepatitis delta testing in everybody who's surface antigen positive, unless there's sort of a resource limitation, in which case then you can go with the risk-based screening. In terms of how you screen, we typically start with the hepatitis D antibody, followed by the RNA if the antibody is positive. So, similar to hepatitis C. Quest offers both. They are clinically available, not FDA approved. Quest also offers a reflex test. So you can order the D antibody to reflex RNA. So that's a nice option. So you don't have to call somebody back in for the RNA. They do not yet offer the B surface antigen to D antibody to RNA, reflex. That's aspirational. But I usually go through Quest. Finally, what do you do when somebody does test positive? So unfortunately, until very recently, there's been no good treatment for hepatitis delta. The antivirals that we use for B are not active against hepatitis D. Pegylated interferon can be used, but not very effective. There is a new medication called bulevirtide, which is an entry inhibitor. It's administered subcutaneously once daily, and this was conditionally approved in Europe in 2020. So our European colleagues have developed more experience with this drug and have been presenting at all the meetings, and we're all very jealous. It's still in FDA review, and I don't know, I don't have any insight into the status of that here in the US. One caveat is that the optimal treatment duration is unknown. There is compassionate access to bulevirtide that's now reopened for a relatively narrow window of patients who have very advanced fibrosis, but not decompensated. And then finally, there's a lot of research into new compounds for hepatitis delta. These are results from a study that was presented at EASL this year, the Solstice phase 2 study, looking at this compound VIR-3434, which is a monoclonal hepatitis B antibody, and VIR-2218, which is a siRNA, so a small interfering RNA. These are both also being investigated for treatment of chronic hepatitis B without hepatitis delta. And what I'm just showing you here is that the combination with both the monoclonal antibody and the siRNA led to a very rapid hepatitis D RNA response. And the monotherapy with just the monoclonal antibody also led to a high rate of virologic response. So we'll have to stay tuned on more results on these compounds. And I just want to close to remind you all that we do have hepatitis B cure studies here for people living with HIV and hepatitis B who are on dually active antiviral therapy and are suppressed both HIV and hepatitis B. We are enrolling a study of selgantolimod, which is an oral TLR8 agonist. It's a once weekly pill. And we're looking at change in hepatitis B surface antigen levels. And coming soon, we will have a study of those two compounds that I mentioned, but in people with hepatitis B with or without HIV. So thank you for your attention, and I think we'll both take questions together.
Thank you both. I will first ask the audience if anyone has any questions.
Two questions. One is, I was surprised at the treatment success rates of people living with HIV in San Francisco from the standpoint of such a high proportion of people are engaged in care. So what's the reason for the gap of that? Even though you said, oh, it's great, it's better, but these are people we know are engaged in care. And then maybe that's for you. And then Jenny, is there any theoretical, when you say like rapid decay for HBV, is there any theoretical benefit, or do we care? Is it on the path to cure? Maybe just to comment on the viral dynamics of that.
Okay, I'll start with the, why aren't we getting to 100% in patients living with HIV? I think I can't comment from the perspective of all of the patients in San Francisco, but in our clinic at Ward 86, we're really down to, I think, like the last mile, the hardest to treat patients, those who are not interested in navigation services or just are not ready to start treatment, even though we offer it every Q3 months, or are still struggling with being unhoused and don't feel like they can keep track of their medications and safely take them. So I do feel like there are, or people who don't have phones and you can't check in on them, which is something that prevents navigation and prevents me from calling to check in on them. And so I do think that there are still patients that are very, very hard to outreach to, but there are places to find those people. I think that at HAP, there's more and more patients that are being identified as hepatitis C positive, and that's a really good place to find people. And it would be a potential place where we might want to do that point of care RNA testing to get people started same day. And then, of course, there's other outreach programs like the VAN and other things to try to meet people where they are to get them onto treatment. But I do think that there are just still some difficulties with reaching patients and getting them started.
I got just one thing to that too, which is I think California, among many other states, has a problem where most insurance will only dispense month to month. So we need to be able to do the min-mon. We don't need to be able to find people and call them and follow up. It's nice to do that and support it, but we can't give them a full course of therapy. We need to be able to do that. And that's a real problem. We're advocating very hard to do that. But and there are other states, Jenny and I heard this at ID Week, Missouri, they'll let you dispense the full course. So we need, just as we've seen all these changes happen with like getting rid of the addiction restrictions and the cirrhosis restrictions, this one has to go in order to help reach these patients because we know we can do it. So, yeah.
And there is data in that surveillance report on insurance status of people living with HIV who are co-infected with hepatitis C, if you're interested. Yeah.
And then to answer the question about the hepatitis delta viral response, so it does correlate with ALT. So ALT levels also drop, and so presumably inflammation in the liver is dropping, and that so there is a benefit to getting the viral load down into zero. I guess the unknown question is the sustainability of that, right? So like, well, you need to be on these medications, indefinitely for viral suppression, or not.
So it's my understanding, I'm not an expert, that in Egypt, right, there was a massive population of people with hepatitis C, and they had a public health intervention in which I guess the vast majority were cured. And I'm just curious if you can tell the story on how that was achieved.
Yeah, so they are the big success story. They, I think, have gotten it was a gold medal from the WHO, the only medal, I don't know, for their elimination. They were the first country, I think the only country so far. And it was a huge, huge investment and a multi-pronged approach, but a huge education campaign, a huge community outreach, national like DAA access, and an algorithm for, getting people on a simplified regimen very quickly. I think the sort of epidemiology of the virus in Egypt was also a bit different than here. So it was the very high prevalence. A lot of people acquired hepatitis C through vaccination campaigns. So I think the stigma was a little bit different also. But they went all in and did very well. So it is achievable.
Thank you. A couple questions from the chat. One is there benefit of Hep B vaccination in a healthy HIV positive person if they had known resolved Hep B by serologies and had waning of the Hep B surface antibody? And maybe I'll add, is there some frequency with which you repeat testing for surface antibody to ensure protection?
Yeah, I would say if the surface antibody has waned and has gone low, there is utility of doing a booster. And, maybe annually antibody testing. I'm not sure what your all practice has been, but
Wouldn't say we're that frequent,
yeah, that's ambitious, but just periodic.
Yeah. And obviously, anytime someone's being treated for hepatitis C, we check and recommend vaccination if they have. But I feel like it does slip through the cracks. Sorry, I feel like hepatitis like B serologies can slip through the cracks. So it is something that like if someone's coming to me for hepatitis C, then I of course check those for obvious reasons, but also it's a good time to recommend people to vaccinate for hepatitis B. Yeah.
Awesome. Couple more. We have some very engaged online folks. I'm very excited about this. Okay, for Hep B cure studies, are there any available for folks with undetectable Hep B RNA DNA on tenofovir? Yes.
Yeah, yes, there is. Yes, there is. That's the Salgan-Tolamod study. So undetectable Hep B DNA, as long as they're on a tenofovir containing regimen or entecavir for at least 5 years.
Excellent.
Yeah.
Okay. Reach out to
Yeah.
Annie. Any other questions in person Great. Okay, let's see here. A couple more. Among people living with HIV and chronic Hep B, whom would you not screen for HCC based on age or any other criteria?
That's a great question. I feel like the HCC screening is not well defined in people with HIV. I tend to follow the same guidance as the ASLD guidance, which is, I didn't show here, but there's a lot of, it's kind of complicated. But essentially men after age 40, women after age 50, anybody with cirrhosis, anybody with a family history of HCC or a first degree relative, anybody with Delta co-infection.
Fantastic, thank you. And then for that same patient, say living with HIV and chronic Hep B being treated, aside from periodic HBV DNA monitoring, is there any utility to periodically checking other serologies like e antigen?
Yeah, so I'll check e antigen and e antibody in everybody before starting treatment. And then if someone's e antigen positive, I will continue to check to look for e antigen seroconversion. So if they are e antigen positive, I think there is utility because you want to see, if they become e antigen negative. I think every 6 to 12 months is fine to check that. In my e antigen negative patients who are hepatitis B mono-infected, I do check a surface antigen, and who are suppressed, so their DNA is suppressed. I'll check an annual surface antigen. The chance of it being negative is like 1%, but it does happen. And so I have had people seroconvert. So I think it's a little bit different scenario in somebody with HIV and hepatitis B, because you're not necessarily going to change what you're doing with the surface antigen negativity. But, I think it's reasonable to periodically, maybe not annually, but periodically check that as well, if they're e antigen negative.
Awesome, thank you. A couple others, if we have time. I think related to an audience comment, for someone with an isolated core antibody positive and known surface antigen and antibody negative, would you recommend checking Hep B DNA before offering vaccination?
That's a good question. I don't think you need to. I think you could just vaccinate. Yeah.
And then please wave your hands at me if you have anyone else in the audience. Someone asked, how do we order hepatitis D testing at San Francisco General? Is there anything special that we need to know?
I can't answer that one. How do you guys order your Quest
I'm
labs?
pretty sure I did this recently. I think it's I think I had to do a miscellaneous send out order. And then I looked up the code at using like the ZSFGH like pathology labs that are offered. Yes, but if that person wants to email me, I can give better instructions.
Delta antibody is in the drug, like you can order.
Yeah, it was the RNA that
RNA you can just order as a send out, which we rarely need to do, but and
we did have one recent patient.
That's right.
Yeah.
That's right. But the Delta antibody, and I would say just everybody needs to have a Delta antibody if they're surface antigen positive. And the data suggests that we as a community do a very bad job at that. So myself included. So just put that on your radar as you're going through your Hep B primary care, just get a Delta antibody.
Naive question, but is the Delta antibody like 100% sensitive for Delta? Do we ever need to think about other diagnostic tests, or antibody negative, we're done?
So I don't know the exact performance of the antibody, but it's not perfect. I know that. So I think if you strongly suspect that they could have Delta, then you could just do the RNA also. But usually it's the antibody just for the screening purposes.
Perfect. We're just past the hour. So thank you both so much. Let's give them a round of applause.